everyone, and welcome. I'm Dr. Chelsie Rohrscheib, head sleep expert and neuroscientist at Wesper, and I'm thrilled to have you today for a very special conversation. I'm honored to be joined by Dr. Atul Malhotra, one of the country's foremost leaders in sleep and respiratory medicine. Dr. Malhotra is a professor of medicine at the University of California, San Diego, a past president of the American Thoracic Society, and a highly respected researcher whose work has transformed how we understand and manage sleep apnea, central sleep disorders, and respiratory physiology. Today, we'll explore key questions about the future of sleep diagnostics and therapy, particularly the limitations of relying on single-night studies, the value of longitudinal monitoring, and how we can better detect and treat central apnea. So let's dive in. And thank you so much for joining us today. We really appreciate it.
Thanks for having me.
Absolutely. So to kick us off, my first question is, how important is longitudinal tracking of multiple sleep and respiratory patterns rather than relying on a single night study or single metrics? In your recent experience, how does tracking over time influence therapy decisions?
Yeah, it's an important question. Traditionally, we thought of polysomnography as the gold standard for a diagnostic because it gives us a good snapshot in time. But I guess we learned the hard way that that is just a snapshot in time, and lots of things can change either night to night, or over the weeks, or over the months. So, for example, within a night, depending on body position or REM sleep, sleep apnea can change considerably. Some people sleep in one position one night and a different position the next night. So more and more data are suggesting that multiple nights of data may be quite helpful. There was a paper in Chest from a former trainee, Danny Eckert, who was trying to predict hypertension, high blood pressure, from a single night test, and it wasn't very good. If you took 30 nights a day, if you took longitudinal data, then it was quite accurate in terms of predicting high blood pressure. And I guess there's a lesson learned that a snapshot in time is just that. We've learned that as well from some of these wearable technologies where people bring in longitudinal data and we see how much things are changing night to night or even within the night. That can vary as well. Things like alcohol intake can change from one night to the next. And so the getting an average representation of what's going on requires serial data like that. The other part of that situation that's changed somewhat is issues around weight loss. So people are losing body weight, like with these GLP-1 receptor agonists, tirzepatide. I ran a big study in full disclosure, as you may know. And so people are moving targets more than they used to be. So patients are gaining weight, their sleep apnea may be getting worse. If they're losing weight, their sleep apnea may be getting better. I find it's quite helpful to be able to track serial data to motivate patients' weight loss or other behavior changes. So when patients see they drink a lot of alcohol, their sleep apnea is worse, and that motivates them to, maybe reduce alcohol intake. And similarly, if they're losing weight and they see their sleep apnea improving, then that motivates further weight loss. And so the serial data really can be quite helpful.
Yeah, that's really insightful. It's clear that single night studies may not always tell you the full story about your patient. So building on that, let's talk about how we evaluate sleep apnea severity. In your view, is oxygen desaturation alone sufficient for guiding therapy, or are we at risk for missing important clinical insights if we focus solely on oxygen-related indices?
Yeah, it's a good question. And it's actually a hard one to answer. So I was recently the lead author on a global consensus on the AHI, the apnea hypopnea index, which is the number of cessations plus reductions in breathing per hour of sleep. And the global consensus was that it's not very good, but it's the best we have. So that we don't really have better metrics. And I think what it comes down to is it depends what your question is. And so Naresh Punjabi in Miami has data on this. If you look at 4% desaturations, that's predictive of hypertension. If you look at 2% desaturations, that's predictive of insulin resistance. If you look at duration saturation below 90, that predicts platelet aggregation. Ali Azerbaijan has shown that the hypoxic burden, the degree of hypoxia, can predict cardiovascular risk. The arousal frequency in the brain, the EEG arousals, can predict memory consolidation. Nothing's a very good predictor of motor vehicle accidents. And so it becomes a matter of what the question is. Just using a pulse oximeter, just using the oxygen level, certainly doesn't tell you the whole story. But there's no ideal metric. It's not surprising that sleep apnea affects so many different biological systems. It's not surprising that one yardstick doesn't predict everything. It would be surprising if I have a metric that predicts diabetes, cancer, Alzheimer's, and car accidents. You wouldn't believe me because they're just very different biological systems. And so I think we need to look at the whole patient, look at symptoms, look at what they're experiencing, what are the risk factors, and what are the issues of greatest interest to them. So some patients come in where snoring is their primary problem. Others were concerned about cardiovascular risk. Others were daytime sleepiness. I think individualizing that decision can be quite helpful rather than relying on a single metric like the apnea hypopnea index or degree of desaturation.
Mm-hmm. Yeah, so that really highlights the complexity of patients and how they can each be different. Even if they share some similarities, like a similar
Right,
AHI, they
right.
might be completely different when it comes to symptoms and risk for these chronic conditions.
And what their priorities are. So some people come in and two identical patients. One is very concerned about their snoring for social reasons. Others is oblivious to that and may be concerned about something else. And so I think that is part of individualizing care and taking care of the whole patient.
Right. So on that note, do you have any scenarios that you've run into in your experience where relying on a single leading indicator like AHI or SpO2 caused your team or another team that you're aware of to miss meaningful pathology or even lead to care that wasn't sufficient?
Yeah, I had an example last night. Actually, I was reading sleep studies just after work, and there was a patient who had a home sleep test, and it was totally normal. And so I read it as a normal test, and I got a my chart message on Epic from that patient saying, "Yeah, I was really sick. I was coughing and sneezing all night. I didn't sleep at all." And I had no way to know that from the home sleep test. I just read the test as fairly normal. I couldn't tell that they were basically awake all night, and that test was invalid. And had the patient not sort of volunteered that and communicated to me in a timely manner, I would have sort of put out a report that was misleading. And in reality, that test was invalid rather than normal. And I think that is a very different situation. So in that context, you could either repeat the test or do a polysomnogram where you get additional data on the EEG and get sleep stages and all that, or get serial multiple nights of data so that if they're consistently in one degree of severity compared to another, then you'll get that with longitudinal data. You don't get that from a single night. That might be an invalid test.
Yeah, for sure. I think so. It's always crucial to double check when your patients are inconclusive because you do see that variation from night to night, and not all technologies are created equal. Let's quickly shift, and which is somewhat related to that topic. Let's
If
talk to
I,
the home sleep testing technologies that are currently available.
if I
Um,
may, if I may add to that, Chelsea, sorry to interrupt
sure.
you, but if I may add to that, we get this a lot now because more and more primary care doctors are comfortable ordering sleep tests and interpreting them. And if it's clear cut severe sleep apnea, then it doesn't require a lot of expertise to say, okay, this person needs treatment. Where it can be more subtle or more nuanced is in patients who have a normal test. Primary care docs just will often say, "Oh, it's great. The test is normal. You're fine. Worry about something else." In fact, if that test is invalid, or if you happen to have a particularly good night and you didn't look serially, you didn't look for multiple nights of data, it could be misleading. And so I often say the expertise is more required to interpret a single night normal test as opposed to a severely abnormal test where the treatment is clear cut. And so that is important information to communicate to primary care physicians. A single night home test, you need to put that in context. And what I'll often start by asking the patient, "How was your sleep that night?" And they say, "I was awake all night because my kid was screaming." Then that test may not tell us very much.
Absolutely. And that actually made me think of something that recently came up. So, one thing I think we haven't done a very good job of is educating non sleep physician providers, so PCPs, cardiologists, dentists, about what sleep apnea actually looks at and and how to identify those patients because they can be so easily missed. And there's a lot of stereotypes about what a typical sleep apnea patient looks like,
Okay.
also about testing. So I think the more education we can do, the higher our rates of diagnosis and treatment will be.
Yeah, exactly right. And not just the higher rates, but also more accurate in the sense that if you end up making a decision based on what ends up being an outlier or ends up being a particularly good night or particularly bad night, that might be misleading as well.
Absolutely. So following up on that, let's shift to home sleep testing technologies. I'd like to ask you about PPG-based technologies specifically because they seem to be a dominant technology for home sleep apnea tests currently. What do you see as the main disadvantages of using PPG-based technologies for sleep apnea monitoring and diagnostics as compared to more traditional airflow-based measurements?
Yeah, I don't have a strong opinion about which technology to use. It's a bit more, in my view at least, the diagnostic sensitivity and specificity. There used to be a lot of emphasis on how many channels. And I used to joke about this, saying you can count how many toenails somebody has and come up with the number 10 and say, okay, this has 10 channels. And that would be completely useless information because I don't care how many toenails somebody has in the context of this discussion. And so, what I look for in terms of a home sleep test and the technology is what the diagnostic sensitivity and specificity is rather than how many channels or which channels. It's like, how good is this test? Yeah.
Okay. So this brings us to another major question for the field. So, given that most home-based platforms do use PPG and not airflow, how can clinicians weigh the trade-offs in signal quality, event detection, and clinical decision making when using these tools?
Yeah, again, I encourage people to look at the diagnostic sensitivity and specificity of these various tests. If they've been compared against gold standard polysomnography and we know that they're giving information that's helpful, then that's great. If you get there's a lot of technologies you can find on the internet or find that have been either inadequately studied or studied in single centers or studied in specific individuals, that can be more problematic. So give you one example. There's a lot of discussion these days about the pulse oximeter and how
Mhm.
that may vary with various different skin colors. And so there's a New England Journal paper by Schoeding a few years ago suggesting that with people with darker skin, that the pulse oximeter may not work very well. And then so using technologies that rely more on airflow may be helpful in that context where the pulse oximeter may be less reliable.
Okay, for sure. So, based on that, let's quickly jump to another topic that's important and something that's often overlooked in home sleep apnea diagnostics. Let's talk about central sleep apnea. So, obviously, most of the viewers watching know that central sleep apnea is nowhere near as common as obstructive sleep apnea, but it does still occur in a subset of the population. And when a patient does have central sleep apnea, even if it's mixed with obstructive sleep apnea, that can really complicate treatment. So, why is it so important to accurately diagnose and monitor CSA, even when obstructive sleep apnea is the primary concern? What kinds of clinical consequences can arise when central events are missed, especially by home technologies?
Yeah, it's a great question, Chelsea, and I'm glad you asked. There's at least two or three reasons why I care if my patient has central apnea. There are kind of defeatist approaches where people say, "I'll just give them a CPAP and see what happens." And the reason I want to know if my patient has central apnea or not is for two or three reasons. One is I want to know why. So there are patients with heart failure who have Cheyne-Stokes breathing, which is a very different entity from obstructive apnea. And in many cases, those patients require optimization of heart failure management or therapy. There are newer treatments like phrenic nerve stimulation that are available for those kinds of patients with central apneas. And so I want to know that rather than just giving them a CPAP and things. Similarly to opioids, there's an opioid epidemic that we're all aware of. Many of those patients will have central apneas. I have lots of patients who come in with central apneas who don't volunteer that they're taking painkillers or they're on opioids or whatnot. Often they have bradypnea, a slow respiratory rate, and they'll have central apneas like that. In those cases, reducing the dose of the opioid can be quite helpful. They don't need CPAP necessarily. They need a good doctor who can help them manage their pain or manage their addiction or whatever their issue is. And in those cases, that can be helpful. So I want to know why they have central apnea. That's one thing. Two is, as you alluded to, the response to CPAP may not be very good. If you put somebody with central apneas on CPAP, um, they often get insomnia when you put them on treatment, or some get treatment emergent central apneas if they didn't have that already. And just expecting a good result from run-of-the-mill CPAP in that context may be a problem. And so in some cases, we have some data on ASV, adaptive or auto servo ventilation, can be helpful for patients who have central apneas and struggling with CPAP. And so there's a rescue strategy there. There's more and more efforts with pharmacotherapy, drugs like acetazolamide or other agents that can be helpful in that context. So it really does change management to know if the patient has central apnea or not. And that sort of defeatist approach of just give a CPAP and see what happens, I think is not great medicine. I don't feel good about giving my patient the wrong treatment. And if I don't look for the underlying cause, I could be missing something, the elephant in the room we talk about sometimes.
Yeah, and that's an important reminder that when CSA goes unaddressed, outcomes can be profoundly affected.
Right.
So clinicians have to be very, very careful when testing their patients. And so on that topic specifically, what therapeutic trends or innovations are you seeing in the management of central sleep apnea? Are we as a field adequately equipped to treat CSA in routine practice, such as by a PCP or a non-sleep physician clinician?
CSA is one of those ones that is tough. I think most of these probably do require a subspecialist. Run-of-the-mill OSA, maybe less so, but for CSA, it is more nuanced. Trying to figure out the underlying cause can be tricky. It's not always obvious when I see these patients why they have CSA. And to your question, Chelsie, in terms of what do we have for treatment, in full disclosure, I consult for Zoll that has the phrenic nerve stimulation. They have some pretty good outcome data now that in central apnea, the phrenic nerve stimulator can be helpful to stabilize breathing. And they actually have some brand new data that I find quite interesting, where if you treat central apnea in the context of impaired cardiac function, the cardiac function can improve. If you stop the stimulation, in fact, there's a permanent improvement in the breathing pattern because the cardiac function is no longer impaired. And so I find that quite compelling. And so, I think they need some more phase 3 randomized controlled trials, but the idea of using phrenic nerve stimulation in central apnea, I think is interesting. I mentioned earlier with the opioids, if you could reduce the dose of the opioids, that could be quite helpful. We have more and more data on acetazolamide, and we're involved in a number of clinical trials looking at various agents to stabilize breathing in the context of central apnea. So it is an exciting area. There are lots of people looking at different agents that work on the carotid body, for example, that may stabilize breathing as well. The devil is in the details, though. There's lots of reasons, as I mentioned, why people get central apnea, and this kind of one-size-fits-all approach is probably not going to work. To that point, the Advent HF study was recently published in the Lancet Respiratory Medicine, looking at giving ASV, adaptive or auto servo ventilation, for heart failure patients. And different people look at it different ways, but it's basically a negative study. They didn't meet any of their primary outcomes. The secondary outcomes they did meet were subjective, and in an unblinded study, it's hard to make too much of that. It was reassuring, though, because previously the SERV-HF study was in New England Journal of Medicine, where adaptive or auto servo ventilation was actually harmful in terms of treating Cheyne-Stokes breathing. The Advent was at least reassuring that if you treat both obstructive and central apnea in patients with heart failure, at least it's not harmful. It looks to be reassuring, at least, that it's not deleterious. But that Advent study was complicated. It happened during the pandemic, and there was the Philips recall. There's a lot of issues that happened along the way that made that study hard to interpret. But at least I was reassured by the results that it's not harmful, even though the result is negative.
Yeah, the Philips recall was quite problematic. I remember it really threw a wrench in the system for a while. So with that said, with all of the issues that come with detecting and managing CSA, it's more important than ever to be highly accurate in your diagnostic testing. Do you believe current home sleep apnea test platforms are sufficient to detect central sleep apnea, or do we risk underdiagnosis when we rely on them alone? What advantages do you think are needed to improve CSA detection outside of the sleep lab?
Yeah, it's a good question, and it's sort of a moving target, because I get that question a lot, saying this is good for central apnea, and people say, no, for central, you have to do an in-lab test. And then you look at what they're actually doing in lab. It's they have a respiratory belt, they have a nasal pressure or a thermistor, and they have a pulse oximeter, which is basically what you have with the home test in some cases. So if you're measuring end-tidal CO2 and you're measuring other things, blood gases, whatnot, then you get additional information there. But I do think there is some value to the home testing for central apnea detection. You just need a high degree of suspicion for central apnea. So I don't think you miss sleep disorder breathing entirely. It's just you might misclassify it sometimes and assume it's obstructive apnea when it's actually central. So I think that's also part of this individualized care thing. If somebody has a home test and you're concerned about central apnea, then digging deeper can be quite helpful.
Mhm.
The
And
other
I'm
part- Good.
and I'm sure some of the home sleep tests that do use airflow measurement, so like our company Wesper, for instance, that are able to screen and detect CSA are becoming more common and definitely more helpful in the field.
Yeah, so along those lines, I think part of what I look for is diagnostic sensitivity and specificity in various conditions. So if the validation studies were just done in morbidly obese men with obvious obstructive sleep apnea, I don't necessarily need a test because it's obvious what's going on there. When you look at validation studies, you really want to see a good mix of central apnea, obstructive apnea in different contexts, and that can be helpful to give reassurance that the technology is picking up what you want to see.
Absolutely.
There's a lot of controversy as well about hypopneas, about whether to score obstructive versus central hypopneas. That's a longer discussion than we probably have time for today. But I recently shared a global consensus on that Vaishnavi Kundal was the first author on in the Journal of Clinical Sleep Medicine. And so maybe it's interesting to read more about it, but it is one of those ones that is a nuanced discussion, but is interesting.
Yes, I hear that quite a lot about scoring central hypopneas and you know how valid that is and whether it makes a difference to your diagnosis. But yeah, I'd love to chat to you about that later. One thing that's been of interest to a lot of clinicians is advancements in GLP-1 medications for weight loss and potentially treating sleep apnea in patients that are overweight and obese. I know you work in this area. Is there anything you'd like to add about this specifically?
Yeah, thank you for the question. Yeah, in full disclosure, I worked with Eli Lilly on the SURMOUNT OSA studies that were published in the New England Journal of Medicine in 2024. So there was a study one, which is a non-CPAP patients got either tirzepatide or placebo, and study two were CPAP patients who got either tirzepatide or placebo. There was no direct comparison of tirzepatide to CPAP, but the idea was tirzepatide was superior to placebo in terms of the primary outcome, which was the apnea-hypopnea index. And then of note, we pre-specified a number of secondary outcomes and controlled for multiple comparisons. We looked at percent improvement in the apnea-hypopnea index. We looked at body weight, which improved 18 to 20%, which is a massive change. Waist circumference changed by 7 inches on average in the tirzepatide group. We looked at systolic blood pressure, which improved by up to 9.5 millimeters of mercury. The sleep apnea-specific hypoxic burden, a cardiovascular risk marker, also improved. High sensitivity C-reactive protein, another cardiovascular risk marker, also improved. And we didn't just make the numbers look better, but patients felt better. So patient-reported outcomes like the PROMIS sleep impairment and PROMIS sleep disturbance scores, both daytime and nighttime symptoms, improved. Now, when somebody's losing 20% of their body weight, it's hard to blind anything. So the subjective improvements, you take in context, but marked improvements in objective and subjective outcomes, suggesting tirzepatide was kind of a home run in terms of treating patients with sleep apnea and obesity. Of note, we excluded people with diabetes, we excluded mild sleep apnea, we excluded lean and overweight individuals. So study doesn't pertain to everybody, but the people we did give it to, it was a game changer. And I think the important point, I consult for Wesper as well, as you're aware, the important point is it emphasizes the need for serial testing because patients are moving targets these days. I see patients in clinic all the time who have lost 50 pounds or lost 100 pounds, and wherever they were last month is different next month. And so a single snapshot in time from a sleep test 3 years ago is interesting, but kind of irrelevant these days.
Mm-hmm. Yeah, that's actually really interesting. So based on what you're seeing, what would be the ideal testing schedule for a patient going through weight loss therapy? Would it be something where you check in with that patient every month, every few months, every half year?
Yeah, that's something to individualize as well. Many of us have clinics that are really quite busy, so it's easy for me to say I'll see them every month when we know that clinic capacity is not that robust. And so I presented at the American Thoracic Society last week some analyses from the SURMOUNT OSA study where we measured watch pad along the way, and you can start to see separation between control and tirzepatide even within 4 weeks. And so
Oh,
how
wow.
often to check people and how often to retest them and things is an individualized decision. If somebody's taking the med and they haven't lost any weight and nothing's changed, then maybe don't retest them. If they've already lost a lot of weight and they think they can maintain that, then that might be time to consider retesting.
Yeah, so another argument for longitudinal testing that should be standardized in practice. Well, I mean, that's a fascinating topic and definitely of interest. So I think we'll have you back on soon to just focus on that area. I've got a bunch of questions for you in regard to these medications and how it's affecting sleep apnea. But thank you so much for your time today and your insights and your expertise. Your work continues to shape the future of sleep medicine, and we're grateful for the opportunity to learn from you. To everyone watching, thank you for joining us. We hope this conversation has given you practical insights into how we can evaluate sleep apnea care through better data, deeper tracking, and more nuanced understanding of respiratory health. If you'd like to learn more about Wesper and how it's supporting clinicians and patients with AI-powered longitudinal sleep monitoring, please visit wesper.co or reach out to us directly. Until next time, again, Dr. Malhotra, thank you so much for coming on. We'll definitely have you back on again.
Thanks for having me.
Great. Thank you. Take care. Have a lovely day.